Dr. Bala, can I ask you some question? In the 2-3 things which I felt in heart failure with CABG, that when patient has got acute myocardial infarction and they refer to the PE for ejection fraction of 15% and 20%, but most of the time they are hibernating and probably putting them on IABP for a day and taking the PA pressures. And second is the LVIDD. Though the ejection fraction is less, but the myocardium is preserved thickness on echocardiography, and the LVIDD is normal, then the vascularization of these patients is beneficial to them. Is just my observation. I don't have a data.
You have to make a distinction between acute ischemia and chronic ischemia, because the wording is congestive heart failure. That's why I dwelled a little bit on the terminology. Congestive heart failure denotes is very different from acute ischemia or a myocardial infarction which is 8 hours old or 12 hours old. That's not congestive heart failure. There's acute myocardial infarction. And the role of CABG or revascularization is a very different animal as compared to congestive heart failure, which connotes high LA pressure, which high RA pressure, with signs of congestion. Under those circumstances, the role of revascularization has to be very carefully evaluated. I'm sure you must have done as much as I have done. So how often do you see a clear-cut benefit, both short-term and long-term, of a patient who has got pedal edema with CVP of 20, RV dysfunction? They're never going to benefit from any kind of revascularization. That's a waste of time.
Okay. I have 2 questions. So one to Dr. Balakrishnan and other to Dr. Mole. First, I will take Dr. Balakrishnan. Dr. Balakrishnan, in a high-risk heart failure surgery, CABG surgery, what you do, where the ejection fraction is 20% and our PET CT or PET scanning saying clear-cut evidence of hibernating myocardium or ischemic myocardium in that area. So how do you decide? You straight away take the patient for a surgery, CABG surgery? If yes, after that, how do you feel that how the ejection fraction improves in a course of time of 6 to 7 months or 4 to 5 months in high-risk patients?
Yes, as I said, high risk is of 2 types. The high risk can be from the point of view of anatomical factors, from the point of view of age or comorbidities. I mean, you have to take everything into consideration. You can have excellent targets, but in a frail old man with a severe peripheral vascular disease, with a previous history of stroke, with multiple carotid issues, that's a different high risk from a younger patient, but with vasculopathy, with very poor targets, and with poor runoff. So, as I said, you have to individualize each patient. And ejection fraction is a number. You can have an ejection fraction of 30%, and the patient can be very sick. You can have an ejection fraction of 25%. And yet the patient, we all of us have seen patients who have survived 15, 20 years with an EF of 25%. And if the ventricle remodels and they are able to carry on. So the improvement in ventricular function, in my opinion, especially chronic ventricular dysfunction, is seldom dramatic. It's not like an acute ischemia. The improvement in ventricular function is dramatic. That means you have a patient coming to you with a perioperative myocardial infarction, acute myocardial infarction with impending cardiogenic shock. You either stent the vessel or you do a CABG, it depends on how many vessels are involved. And the ventricular function can improve by the time of discharge. The ventricular function can be near normal. On the contrary, if you have a chronic heart failure, a chronic long-standing ventricular dysfunction, the improvement, if you see at all, will be over a period of several months, though all of us have seen this improvement. But even if the improvement is not dramatic, a failure of further deterioration and contribution of the relief of ischemia to the overall condition will confer, I think, a survival benefit.
Okay, another question to Dr. Mole. Dr. Mole, when you do a lot of transplant, I think Dr. Balakrishnan also does a lot of transplant. So you know that cardiac allograft vasculopathy, CAV, is one of the leading causes of late mortality after heart transplantation. It is characterized by diffuse concentric intimal thickening. So you know very well your conventional angiogram cannot evaluate that. Even you do a IVA, there's a diffuse thing, it can also tell that. So how do you assess and what is your percentage of transplant vasculopathy following cardiac transplantation, which is a cause for the late mortality?
Yeah, so we have observed this in our 5 patients so far. and CAV. There are certain patients in whom I have given an old heart and they have got a discrete lesion from first year of angiography only. We do angiography every year and we assess every year at the time of biopsy, we do angiography. And after 5 years, we do not do the biopsy nowadays, but we do only angiography. All these patients, first of all, are on statins from day one. Whatever the age of the recipient is, all the patients are on statins. Secondly, angiography tells us early. Thirdly, if it is localized lesion, which we pick it up very fast, then it is not the vasculopathy. It is this lesion which has come from a donor, and that we can manage it by the stenting there and then. The 2 patients who had a CAV after 5 years and one had after 6 years of our transplant, these patients we have successfully managed by angioplasty.
We have an approach where, as Anwar mentioned, we do an angiogram and an IVUS along with OCT in every patient every year to actively seek evidence of coronary vasculopathy. And we have, I think, revascularized 6 or 7 patients in the last decade, including the youngest has been a 14-year-old girl where we had to do multiple stents on the LAD and then eventually had to put in a mammary. This was an older heart from a 42-year-old donor, so it's likely that some of it was a donor coronary artery disease, which got exaggerated in the post-operative. So we also now routinely put these patients after the first 6 months on everolimus because there's some evidence that everolimus decreases the progression or even the incidence of graft vasculopathy, which is, after all, an immunological injury of some kind.
Over to Dr. Kaushik. Any questions, Dr. Shantes Kaushik? From?
Yes, I had a question for Dr. Pandurangi. What would be the cutoff for putting in an AICD in a patient of HOCM based on the degree of fibrosis? Actually, this is slightly different from the heart failure component, but is there a cutoff for putting an AICD in a HOCM patient based on the degree of fibrosis?
No. It is never on the basis of the imaging system. Whichever the way you would like to look at the fibrosis, there are many ways of looking at the fibrosis. Some of them are investigational, some of them are imaging. The degree of the fibrosis is not going to direct you in a patient with an HOCM or HCM for an ICD. Bala, can I have a question to you, Bala? Good to see you.
Sure.
Thank you, Mahapatra, bringing Bala on the screen.
I could bring Bala pulled from his emergency and all. I cannot get a substitute speaker. So he had done a tremendous, marvelous job.
So excited here to see Bala on the screen.
Yes.
You know what? I just was wondering. It's indeed a surgeon's daring to do a 35-year-old EF of 20%, and then you are somehow thinking of doing his bypass surgery. I do not know why, but then you did it. Tell me, Bala, do you send him home without an ICD?
Ideally, we would like to have an ICD in every one of these patients.
Good, that's it.
But the problem, the devil in India is a cost.
You said that.
In fact, our current thinking is every patient that is waiting for a transplant, I would like an ICD because Anwar Mole would agree. Even today, at least once in 2 months, I see a patient who is waiting for a transplant, who's not dead to the emergency room because he is, and you would have seen him 2 days back in the OPD is fine because he has a VF. The problem is the damn cost. Everything in this country revolves around cost.
No.
Nobody's contesting. So every patient who's listed for a transplant, I would like an ICD in place so that they don't die unnecessarily at home.
Bala,
I'm sure Anwar will agree with me.
Yes. In last 1 month, I had 3 patients dying with the VTAC, young patients.
For very silly reasons, all that they need is a bloody shock and loss of life.
Bala, you would never ever speak about the finances. Come on. You are the guy who prescribes the most expensive therapy, and then thousands of patients are flooding to you. Let's not bring that concept of the finances just because an ICD is going to be prescribed here.
No. I'm not. What I'm saying is it's absolutely indicated. No doubt in my mind.
Okay, now hold a second. You see, there's a bridge to the transplant. There's a bridge to the ICD as well. And Bala, it is you who should bring this concept in. We've got to have this wearable defibrillators being present or the external defibrillators with the family members. I think that should be a great movement in the country.
Is it easily available?
No, you should be making it easily available. What is that you have not made easily available in the country? Why are you asking this question to me?
Because
Yes, go ahead.
ICD is a procedure. And as I said, no, I'm talking not about my practice or your practice.
Don't-
As a general policy in this country, if you were to advise an ICD in every patient with a EF of less than 30%, it's not practical.
I'm not saying that. I'm talking about the patients whom you are handling.
Absolutely, but even in our kind of patients, the overall cost is an issue. Not everyone can afford everything.
Nothing is more expensive than your transplant.
Yes.
No. I beg a pardon here. I beg a pardon here. I don't want to fight, but your CRT is more costlier. CRT is more costlier. And CRT I have seen the patient on CRT after 2 years who were not managing well, ejection fraction went down to 10%, and then they did not have money.
Hold on, gentlemen. Please don't bring CRT here. Don't bring. We are talking about the efficacy. Transplant is a gold standard for heart failure.
Ullas, if I can interrupt,
Yes.
the very fact that we're discussing is something we had a huge discussion in our unit 2 weeks ago as to how to make sure that no other patient dies while waiting for a transplant because of a stupid arrhythmia. And
Yes.
how do you make it affordable or as part of a protocol that everyone who's waiting
Bala can
have
make
an ICD of some kind or a defibrillator of some kind available?
you can make it. And then you have been a prototype of the transplant program. And the bridge to the transplant has several issues.
Sure, I agree. I think this is something we have to
We're not
maybe
focused on.
factor it into the overall cost. It's doable. I agree with you. It's doable. It's a matter of being convinced of its utility.
Yes. Thank you.
Yes,
Dr.
Dr.
Mule,
Mamata.
one of my young patients, 7 years old, got a transplant and she is unbelievably doing very well. So what are the problems which are faced in this subset of patients? She is doing very well. I never expected. And when she came after transplant, I never dreamt that this is the same patient. She was in refractory heart failure, cardiomyopathy, and she has done exceptionally well. So what are the problems in this subset of pediatric patients in the long run?
The donor which will match the size and of the.
No, she has already received the transplant. She is doing well. In the long term, what will happen?
What long will the same thing, CVA or the rejection? But she is doing phenomenally well.
Extremely well.
Her angiographies are all normal till today,
Yes.
and she is doing very well. So I don't expect, but at the end is the CVA. Is the vasculopathies are the most common thing, and is to come out with this. So we have to keep watch on it. Nothing else.
Does the growth of the body create disproportion for the heart which has been transplanted?
No, it grows. No, it grows. It grows with that.
But it was fascinating. I never dreamt that the result would be great. Congrats, transplant surgeons.
Dr. Mule, I have a question to you. See, this vasculopathy always in your practice you come across only on epicardial arteries, or also sometimes you have got a doubt to diagnose the intramyocardial vasculopathy?
No, most of the vasculopathies are mainly because of the immunosuppression medicines.
Yes.
And at the right time, if we change the immunosuppression medicines, as Sir said, to everolimus and all, which you have got everolimus coated stents, right? So which decreases this reaction of this. So even if you put them on, but most of the times we have seen it in epicardial arteries and extensively it's not only one spot or one area, it is through length of it, and we required 5, 6, 7, 8 stents to cover the whole thing usually.
I would like to add something to the, I think the previous questioner raised a point about pediatric transplants and long-term follow-up. One of the things that we have seen, we are now following up close to 120 pediatric transplants. One of the things we have seen is you can have ventricular dysfunction, which is new onset by 4 or 5 years, with a biopsy which is not abnormal. That means the biopsy does not show clear-cut evidence of cell-mediated rejection. And not a very clear, convincing evidence of antibody-mediated rejection. We have seen 3 or 4 patients, and they have responded to steroids or pulse steroids or increasing in immunosuppression. So I suspect some kind of the question you raised about intramyocardial or non-epicardial coronary artery disease is not something we will able to image. So that's really an unsolved problem. But at least I've seen 3, and this is not seen in adults. I've seen in 3 children where ventricular dysfunction, which is not clearly defined by the cause by any of the modalities of diagnosis, and who have responded to steroids. So I suspect there's some element of vasculopathy which is not detectable by epicardial coronary angiograms.
Is this what your observation is? Is this in these last 2 years?
Yes, I mean, because only now we have 5, 6, 7 year follow-up.
Right. No, my point is that in last 2 years also I've seen everything is fine, everything is normal, but market is gone down. And whether it is post-COVID, subclinical infection,
Even,
I do not know.
Because I had 2 patients in the last 6 months who had ventricular dysfunction for which we couldn't find a reason.
Yes, correct.
And
correct, exactly.
AMR, CMR, everything is negative. So, I mean, they respond to steroids, but it's a worry.
Correct. But that I've seen in only last 2 years.
Yeah, I didn't think necessarily COVID because, only now we are reaching 7-year follow, 8-year follow-up in pediatric transplants. We started it 7-8 years ago. So it could be. You could very well be right.
Mahapatra, can I ask you a question?
Yeah, please.
See, I just was thinking, what is the current status in the country with respect to the nuclear medicine, helping us out in figuring it out, those patients who are predisposed to arrhythmia? Maybe it is ventricular arrhythmias or maybe atrial arrhythmias, because we are following certain crude information, not necessarily so-called nuclear imaging, to kind of specifically direct our therapy when we are dealing with ventricular or atrial arrhythmias.
Yeah, see, desynchrony, yes, we can diagnose by SPECT scan. Then we also guide you that you can go ahead with ERT. Then the desynchronous contraction on the phase amplitude analysis can come to the uniform area, and then you can say, okay, fine, the ICD has really done a tremendous job. Desynchrony type of area. So about the other things I couldn't follow. Arrhythmia, atrial arrhythmia, nothing. So now I'm talking about ventricular arrhythmia. Yeah.
The MIBG scan is taking a big step, to look at the.
Yeah, correct. So listen, the iodine, the MIBG scan, the problem is that the iodine 123 MIBG is very scarcely available and not available in India, iodine 123, which is the real term. And about the PET agent, C11 hydroxyephedrine is still, it is on the verge of coming. Once that PET imaging will be available with C11 ephedrine, then we can do the look. This is the myocardial perfusion is almost normal, but if you do a imaging, the hormonal imaging, there is a defect. So viability is okay. The MIBG, the neurohormonal, is reduced. So this is the cause for ventricular arrhythmia. So even if
Dr. Mahapatra, I tried with iodine 131 MIBG. Iodine 131 MIBG. I am sorry, Dr. Prabhu here. Iodine 131 MIBG. The results were good. It was workable. I think we are not using iodine 131 MIBG optimally. If we can try it, it will definitely be of much help.
I have a question, Dr. Prabhu. One can use iodine 131 MIBG, iodine 131, but about the 4 things and the image quality, did you get a good quality image?
No, you can't. Unless you take a longer period of time, the image quality will be not as good as iodine 123.
Correct. That is
the challenge. Obviously.
That is the challenge.
So thank you, Prabhu, coming in, pitching in. See, I have a last one question here. See, when we talk about the non-ischemic cardiomyopathy, we label that as idiopathic dilated cardiomyopathy. We stop, going further down. We start looking at the device therapy or a transplant. I think there is a much role with respect to the nuclear imaging, the PET scanning, and the MRI imaging. On top of that, there are certain blood tests, there are certain other tests. we are not encouraging our physicians to look at the other varieties of cardiomyopathies which could be actually treated. Just because we didn't treat some infiltrative diseases, the patient became a transplant candidate. And then we transplanted or we put in a devices, but that the systemic ailment will continue and then they wouldn't do well. So we should not be making it as dichotomized. One is ischemic and a non-ischemic. And non-ischemic, I think imaging people, the physicians, everyone, rheumatologists, everyone, I think, that when there is a non-ischemic cardiomyopathy, I think that patient needs to be very, very seriously evaluated when the ejection fraction is deteriorating.
Yeah, Dr. Ullas,
I'm sorry for the intervention. Just I'll share my thought process. We have to learn a bit from the oncologist. They have a sort of tumor board where across specialties they sit and discuss. And here the science is progressing in silos. There is no common platform where, except in handful of institutions, a sort of heart failure board or a cardiac transplant board or something of that sort should happen on a regular basis. If such a thing can happen where all the specialties, they can pool in their resources, they can share their ideas, and only then things will develop. Such sort of thinking process will evolve. And I also agree that your argument about the inadequate usage of the device for bridging a transplant, that also will be set aside.
So Prabhu,
I would like to add.
Prabhu, take Bala on the board. Prabhu, take the Bala on the board and make one board for the nation.
Ullas, I would like to add one point to the thing you raised. I could not agree with you more that there is a need to probe deeper into this non-ischemic cardiomyopathy. We had a patient 2 months ago who collapsed after a second booster dose of vaccine previous day. And profound cardiogenic shock, was put on ECMO and resuscitated, and then coronary angiogram normal. We did a biopsy and it showed tubercular granuloma.
Look at that. ATT, where is this transplant? Because
so we would never have diagnosed if she had not landed up in this situation. So we're not investigating enough, in my opinion.
That's correct.
And the example of tumor board is absolutely spot on. Even within the same hospital, the cardiology and surgery, we've never had a culture of now combining and having any kind of sensible meeting. I think it's time that changed.
Dr. Panday,
even the genetic mutation.
I have a question to you. Dr. Pandurangi, how do you decide before putting the ICD, do you do a SPECT scan, find out the live myocardium, and then the ICD should hit in that, not with the scar tissue? Don't you feel like this is a very important subset to decide?
Yeah.
Or do a MRI? Whatever.
Yeah, I think it's a very, very broad subject here. Ischemic cardiomyopathy. When it comes to ischemic, things are very clear. I think it's a chronic ischemic cardiomyopathy. More than say 3 months into your clinic, ejection fraction is not improving. Well, it's mandatory. You counsel them. You please write it up that you have recommended whether they would undergo that. There are some socioeconomic reasons. Ischemic cardiomyopathy, I think it's quite well established with respect to the prevention of sudden cardiac arrest. Now we are talking about the non-ischemic cardiomyopathy. Younger people requires, as Bala said, so much of investigations. How many times we have found, as he said, tuberculosis, sarcoidosis? How many times? And then there are rheumatological associations with cardiomyopathy. But there are crude ways, and of course, a patient needs to afford to be continuously getting investigated. They want the leg swelling to go away and lying down flat. That is what is their aim. The diuretics would take care of it. But what do they not understand is, we would like to hit at the cause, right? So I think, as we said, the board formation of the board is required. Every institution should have, for example, I think I'm very fortunate, like imaging people like you always help us.
Yeah, so, we have tumor board always existing in our hospital. Similarly, heart failure board we can have.
Prabhu, you heard him? Prabhu?
Yes, I am listening, sir. We will do that. I will organize. But then there should not be any distinction between government and private institutions. Yes. Everybody should join.
That's another issue. Okay, I'm not getting to that. Okay. We can. For time being, let's take that out, but we can together. Yes.
Yes,
now we have come to the end. So, anybody has got any questions to ask, or we'll close the summit?